Good morning, good afternoon, good evening, wherever you are in the world. A very warm welcome to Meet Menaca to celebrate you. Today, on episode 97, we are going to be discussing modern keyhole surgery with Dr. Kumar Kunasingam. He's a consultant orthopedic surgeon and a specialist in foot and ankle conditions in London. Before we go further into the speaker, let us see why are we talking about modern keyhole surgery today. Modern keyhole surgery, or sometimes known as laparoscopy, is a type of surgical procedure that allows minimally invasive surgery over the traditional way. There are many benefits to the surgery. For example, it could be less swelling, less pain, decreased pain, reduced complication, quicker recovery. But I'm sure on the flip side, there are difficulties too. We will be discussing about it, I'm sure. So our speaker for this week is an expert on foot and ankle condition, which is a subspecialty of orthopedics and podiatry. Nowadays, keyhole surgery is becoming popular because it is a less trauma to the muscles, soft tissues, and surrounding the foot. This is also helping this to speed up the healing process. On an instant word today, I'm sure it is becoming, no wonder it's becoming popular. To find out more about this subject, you could join us on Zoom. The link is there. Ask questions exclusive to the speaker, Mr. Kumar Kunasingam, who will share his expertise on this field of medicine. Why Mr. Kumar Kunasingam today? He graduated in medicine and surgery from Guy's and St. Thomas Hospital with a Bachelor of Science in Experimental Pathology and Genetics. He initially taught anatomy under Professor Harold Ellis at Guy's, King's and St. Thomas Medical School, whilst training in general surgery and orthopedics within the London Deanery and Southeast Thames rotations, and now helps with training there. Mr. Kunasingam underwent subspecialty training in foot and ankle surgery in Sydney, Australia, which included minimally invasive keyhole techniques. Whilst in Sydney, he was involved in the treatment of elite athletes. He's a leading expert in minimally invasive keyhole bunion surgery in London. In 2015 to 16, Mr. Kunasingam and his colleagues set up the foot and ankle unit at Croydon University Hospital. His practice covers all aspects of foot and ankle surgery, striving for excellence using evidence-based methods. He's an expert in minimally invasive surgery, with most of his cases performed as day case procedures with quick recovery times. So no wonder we have invited Mr. Kunasingam to be on the show. A very warm welcome to you.
Thank you very much, Menaca. Thanks for having me. I'm very grateful to be here and see all your lovely smiles and hopefully share some great stories.
Real pleasure to have you. So little about the show. Meet Menaca features experts in their respective fields like today, and also real people sharing real stories to create a positive social change. It's a vibrant 90-minute multicultural online talk show to celebrate each and every one of you. We would be delighted to have you join our show for the live stream airing every Sunday at 2 o'clock at London time, in summer 6:30 in Sri Lanka, India time. You can join the event either on Facebook Live or preferably on Zoom Live so that you can get the opportunity to ask the questions yourself. Please do support us by subscribing to our YouTube channel, Meet Menaca, so that we can have a bigger impact across the board. Please support us by sharing this information with people who could benefit from this. And that is the entire purpose of this show. So without further ado, let's dive in and learn from Mr. Kunasingam what we can do better and what we should do. So thank you so much for being in the show again. So I have been thinking about this show and what you are going to bring to our audience. I think I had to ask this question. What made you choose orthopedics and then specialize in foot and ankle surgery?
Thanks. Yeah, and so I think the orthopedic question is a really straightforward one for me, and I think most of you there who know orthopedic surgeons or surgeons as a whole will know that we're quite impatient people, and I like to fix things. I want a quick fix, and I want to get people better, get them back on their feet, and get them going. So I think it's a reflection of personality. A lot of us in life generally choose professions based on either the experiences of our parents, our friends, our peers, contemporaries, or personality traits. And I think that's something that's slightly newer, and I'd like to see evolve both with trainees and young people growing up, is to have a look inside themselves and see what makes them tick, and then maybe consider future planning. So for myself, certainly that was the case. I was lucky enough to do lots of different specialities within surgery and trained as a doctor, so did my medical degree and went forwards. But this was the one thing that really sort of grabbed me. Orthopedics, you can do trauma, so broken bones, which is every day a new challenge, as well as the elective work, so worn out joints, tissue, tendons. And to reflect on the last part of your question, which is about the foot and ankle surgery specifically, you can pretty much do most things with foot and ankles. So I can put cameras in, do arthroscopic work, I can do X-ray guided keyhole work. In fact, I've done the same keyhole work or minimally invasive work, which I call keyhole for communication, to make it easier for patients to understand, using virtual reality. So there's new modalities that you can use there. Tendon works. I'm sports qualified, so I do a lot of sort of rapid recovery tendon and ligament work. To my diploma in sports and exercise medicine, just to add to the multitude of letters that we all collect on our journeys. And so, yeah, it gives me the opportunity to do lots. And I guess the final part of that question really is, I do consider foot and ankle to be a bit like the Wild West, in the sense that there's still evolution and development. There's still the opportunity to add to the table, to add value to patients, but also to colleagues around the world. And it's been great to me. It's allowed me to fly around and teach what I do to colleagues around the world, and share these experiences, which is what I was lucky enough to receive, and hopefully give back as well, which is kind of cool. So yeah, I feel very privileged to be in this specialty.
Thank you so much. I'm sure your patients are very lucky to have you as well, because when the profession is dedicated and has the passion to do something, and I think it definitely comes across. So thank you so much for that. Why do you think it is important for people or our audience to know and understand about keyhole surgery? Because not many people are aware of what the difference is, and why should they know about this topic as such?
Yeah, no, thanks. That's a great question. So I think this is, again, reflecting on one of your heartfelt topics, which is communication. This is crucial. So keyhole surgery, minimally invasive surgery, less invasive surgery, arthroscopic, laparoscopic, they're all terms to basically outline getting in and out with as little disruption as possible. I use the term keyhole because you can all understand the analogy of entering a room using a key to then move furniture around, shift things around inside, paint the walls, and get out and close with a key, rather than knocking the whole wall down, taking the roof off, blowing out the windows, getting in and disrupting and then moving on. And you can then extrapolate that analogy to the foot, specifically for me, foot and ankle. It's a very delicate area. There's lots of very thin layers. It's essentially sort of skin and bone, but there's lots of joints, lots of ligaments, tendons, nerves, blood vessels. So getting in and out with less disruption is a much nicer kind of way to manage patients' pain, length of surgery, expectations afterwards, the ability to walk and get going. A lot of my forefoot work, so the bunion work, for example, patients can get to the gym for non-impact exercises the day after surgery. And as we are coming out of COVID, and the topic of well-being is now firmly, for the right reasons, on the table, I think it's a big thing that people can actually get back to a quality of life, what they enjoy doing, not take time out too much from family, kids, busy jobs, work, etc., to do this. And there's a balance, but it has allowed patients to, for example, see clients the day after surgery. I've had surgeons I've operated on that have gone back to work, still in the bandage and operated. I've had other members of staff that will come and help me in theatres afterwards, still in the bandage and getting going. And, it's just a progressive way of doing something that in the past was quite brutal. It was open surgery, lots of, big deep cuts, lots of filleting, looking at the anatomy. As you've kindly read in my resume, I taught anatomy, and I loved open surgery. It was great. I did it for many years, but the ability to do something slightly better is hopefully a principle that we can all use in our lives to evolve everything we do. And that's certainly something that I think is a true reflection of why I do this type of surgery, and why actually I was lucky enough to be taught the principles of this type of surgery on my fellowship in Sydney, and bring that information back to the UK and then still share it around the world, which is kind of cool.
Sure. Thank you so much, because I think anatomy is one of the subjects, either you like it or you don't like it. And anyone who is involved with any part of health industry will know it is perhaps not the easiest subject to master, for sure. So for you to go and teach anatomy, you must have been really good at it. I know that, we used to joke when we were doing the exams as medical students, dental students, we used to, when we see a skull or skeleton, we're very scared. We don't want to go nearby. But you can be just before this exams, you can see a lot of students literally going to sleep with the skulls and skeletons. So you must have been really good. What better way to practice than doing some kind of surgery which is closely related to anatomy, really. So thank you so much for that. I know you have trained in different countries, for definitely in the UK and Australia. So have you adapted your practice with these experiences? Has it made a difference for your practice?
Yeah, that's a great question, actually. Because as you're aware as well, everyone practices slightly differently around the world. Even if you look at the background demographic of healthcare itself, access to healthcare, and then how to progress healthcare, it's all very, very different. Expectations, outcomes from patients are very different as well. And so I've been lucky, actually, to take some of the resources and skill set from the Australian surgeons that I worked with, especially in terms of the principles of turnaround, quality of care, but also efficiency back to the UK, and integrate that into my practice. And it's a bit like learning to run. They really taught me fitness. You have to be super fit to keep going. And patient safety is key. It's always at the center of everything we do. But to think of how to streamline the process, trim the fat, so to speak, and offer a little bit more to patients. I've really enjoyed that, actually. And it's seen, I think, more constructive units of activity performed in better time segments to benefit the hospital and the patient, because it means then the flow, preparation during the day, you don't have to come in for as long. It's just a nicer experience. I've quite enjoyed that. So that's probably the biggest thing that I brought back and seen. And I think, just briefly reflecting on another type of situation I was involved with for the tsunami, I went out with a colleague and did a bit of recovery work. We set up a mobile medical unit in Sri Lanka and just went up and down the coast. And that was very interesting to see what was available, and probably how privileged we are in this part of the world in terms of access to seeing professionals, skilled professionals, implants, things that we use on a daily basis, so it's quite nice. I ended up using cardboard and some parts of a palm tree to immobilize a forearm fracture, because there was nothing there compared to what we're kind of spoilt with here, actually. So it's quite nice. I like thinking out of the box. It's a bit like being MacGyver, but it's good.
I can totally, not on that scale, but as a dental student or interns, we used to go to slums in India and to provide dental care, dental camps, we used to call it. And it's a totally different ballgame, isn't it, when you're on the slums and trying to provide care with the least equipments, the minimum things what you have. So, hats off to you for doing that. And it's a great, we need more surgeons like you who would like to go and do those things and provide care for those underprivileged and in those circumstances. So thank you so much for that. This is a question I think a lot of people have on their mind, but not many people ask, perhaps. If there was one thing you could change about the NHS today, what would it be as a frontline surgeon?
Thanks. Yeah, it's another great question, and it's I guess a tough one to really structure. But I think autonomy, inclusiveness, transparency would be the way I would sort of approach that. Because I do think there's large volume of people within a superstructure of the NHS. I think at one point it was top 3 employees on the planet, so Indian Railway, Chinese Army, and then the NHS. And with so many people who are clearly motivated to give up their time, effort, and work unusual hours in systems where, you know, sometimes you don't see daylight when you're doing particular shifts. It's very much not just through medicine, but through nursing, through physio, through occupational therapy, all of the subspecialities that help the patient pathway. I think there's a lack of identity that's given to a lot of people on this journey. Voices are now being heard through the wellbeing sort of recovery COVID type setup, so people are able to put their hands up and say, well, this is my experience. But I think there needs to be a little bit more of that, and inclusivity in a positive way to share ideas and experiences to make the situation better, because it is a huge structure still and doing a lot of great work. But we've all got, you know, even on this call, probably 10 ideas each of experiences that either we've had ourselves or family members or through our own experiences through work that we'd say, wow, this would make a much better NHS for everyone, really. So it is there for everyone. And I think we as a group and a community should be able to probably voice those. To that end, I think, you know, we do try and enter sort of different committees and boards and have that voice, which at my stage of career is quite helpful. And I feel privileged to be able to do that. But part of that movement is to actually listen to other people as well. And I think that needs to be a bit more transparent.
I speak about resilience a lot. And I think well-being of healthcare professionals also have to be in the forefront. Be able to care for others. You should be cared for first, I think, and it's a missing piece sometimes. Let's get into the keyhole surgery itself. As a patient or a carer, what should someone consider before having a keyhole surgery?
Yeah, I think probably you see with your patients as well, it's doing your due diligence. I'm sure people, you know, should or would look up what you do, both in terms of the type of procedure as well as the reputation of the person performing it. And again, I like analogies, you know, communication. And if all of us wanted to buy a fridge now, we would go to the John Lewis website and look up 5-star review, and probably wouldn't even read the review. We'd just buy the fridge. This is a great fridge. I'm going to buy it. Everyone's bought this fridge. I don't think there is as much of that as possibly there should be within healthcare. And, you know, I could extrapolate from that analogy and say maybe we'd read about the cooling system and how many shelves it's got, and, you know, manage our expectations of what we're going to get in terms of the fridge, the size, the delivery time. And again, I don't think, you know, there's enough of that goes on. So I think, again, you know, we, through my various different hospitals, have tried to add value by patient experiences, sharing both written and spoken word and video form, to then showcase and show other patients what they may expect, which I think is quite nice. And it's different within the keyhole world because you've got a small volume of people able to do a skill set that is a little bit unique. You know, it's definitely something that needs a level of training, confidence, and support, of which, you know, with my teaching hat on, I try and provide. But if there are, for example, I've had a patient recently, it's good to use examples without names, but she went to see a really well-respected, very, you know, good surgeon about having open surgery, but she wanted the keyhole surgery and was told, actually, there's problems with it, you know, we don't do it. And that was a personal experience of the person she was seeing. An incredibly educated woman who understood, you know, the system, but then said, right, fine, I trust this person and I will go with this. And when she saw me, she was, you know, a little bit upset because the recovery was quite protracted. It wasn't as expected. It was bilateral rather than staged. It was a lot more, didn't really manage expectations. There was some overlay to this. And I didn't offer further intervention. It was more an opportunity to then build into the principles of soft tissue sparing or, you know, recovery associated with keyhole work that I was able to implement into the open work. manage expectations and get her going. And she's a lot happier and in a good position now. But then she was reflecting on this, and it's her words that are like quite poignant here. She just didn't trust her gut. And I think as a patient, you know, as a friend, as a carer, as a member of your family, we all trust our guts, and we have to go with something that we want primarily, i.e. you've looked something up specifically for rapid recovery, keyhole surgery, return to life, versus the person sitting in front of you who may not have that experience. And therefore it's up to us to do the due diligence to go to John Lewis rather than to go to, you know, another store. I mean, I'm not being sponsored by John Lewis, don't misunderstand me. But, you know,
you don't have any shares in John Lewis, I'm sure.
To go with that kind of reputation. So, and look, we're all online today, right? So we've got enough tech savvy to do this either ourselves or with friends. And that's why I encourage patients to look and search and, you know, reflect on what they read and see if it works for them. And I don't think it takes a large volume of time. I think it's something that can be done fairly quickly. And yeah, I've just had the question come in about shares. I haven't got the shares. I like it.
Yeah. Yes, I'm sure there are better places to put the shares on right now.
Yes.
It's surprising, isn't it? When we even want to go out for a meal or a holiday or to buy a refrigerator, like you said, we would do enough research and reviews. Then why wouldn't you then look up or do the needful research for something as important as your own health?
You're right, Menaca. I think, you know, you only get this one chance, don't you, often? And you know, sometimes you don't. You can have revision surgery or go back for another opinion. But it's a unit of time. It's your unit of time. It's your unit of activity. It's your time away from your family, your loved ones, work, etc. And therefore, it's worth just optimizing that, making the best experience possible. And you know, you're right. We go on holiday and we want to know everything about it. You know, we want to know what's on the menu and, you know, what to order and to look forward to that experience. It's kind of cool because if you do get, and I'm sure you get this as well, and I'd love to hear your thoughts on this, but patients who know what you do, they make our jobs and lives a lot easier because they can also answer the questions for you. And as I say to a lot of them, when they leave the first consultation, you can now do the surgery yourself. You know, because you've done the research, you've done the due diligence, and I think it helps the recovery as well. I think it speeds up their process. I don't know if you find that with aftercare when you see your patients.
Yes, in dentistry particularly, we don't have very invasive surgeries like you do, or I'm not expert enough to do those things either way. But the people who do the research, ask the right questions, and want to know and ask questions from the healthcare professionals always get the best, in my opinion, because I always say to my patients, it's a partnership. You know, like both of us have to work together. And, you know, I can hold your hand, tell exactly what you do. It is a bit like coaching. I do coaching as well. So it's a bit like coaching. I can help you get there, but you still have to walk there.
Absolutely. So, I love that analogy. In fact, often when I see patients who've had some surgeries that, you know, they've come for a second opinion or consideration of revision with recurrences, then the first thing I say is, you know, we're about to go on a journey together. The two of us, you know, we've just met. I know you've been through a lot, but we're about to go on a journey together. And I think it's really nice because then it is an element of handholding, there's a trust and the establishment of that relationship, consolidation of that, and then, you know, hopefully move forwards together, which is quite nice.
Thank you so much. I'll borrow that sentence to begin with.
Absolutely. Absolutely.
Thank you so much. So Keyhole is becoming popular and more commonplace. So I'm sure all our audiences and generally the public wants to know what are the advantages, disadvantages are there for a keyhole surgery. I think it is a must know, isn't it? So as an expert in this field, what would you say?
So yeah, thank you. Another great question. And we to stratify this again, keyhole or minimally invasive surgery can be applied to virtually all parts of the body, actually, from general surgeons, urologists, spinal surgeons, and specifically now going back to me within orthopedics, foot and ankle. And so it's really important to understand what it's about, essentially. And this is to utilize tiny little cuts to use different instruments to open surgery to then access the parts of the body that are being operated on, so the bones, for example, to break or osteotomize those bones, and then to move them into a better alignment and fix them with, often with screws that stay in internal fixation, which again, modified implants. And so it's getting in and out. And I think, the disruption to access that part of the anatomy, it is quite a large dissection through open approaches, conventional methods, that then multiple layers are disrupted. So in itself, I'm sure most people can imagine that creates a large volume of pain. So there's a lot of inflammation associated with that, a large pain generator. The way the bones are then cut and realigned with the way I do it means you can walk on it immediately afterwards, versus the vulnerability of the bones breaking with open approaches. So that's why open surgeons are limited with the way they put patients in post-op shoes, this big Darko offloading shoe, which is a sort of 4 or 5 inch heel, and there's a platform at the front to support the operated foot. Whereas I'll just use a flat strappy shoe, or say to patients, just get some Crocs, oversized Crocs, to be more comfortable. And then they're not imbalanced. So they don't come in saying, crikey, I've been like this on one foot and this on the other. I'm off tilt, my back hurts, my knees hurt, my hips hurt. And it's a better experience. And because they're loading it immediately, they can get on with life. So when I started in London, for example, I had some very experienced physios who came and said, right, post-op protocol, how many minutes per hour would you like your patients to elevate their feet? And I didn't understand the question. I don't know what you're talking about. And he said, 50, 55, 57. I'm like, hang on a second. That's basically immobilizing someone fully in bed. So I'm like, no, the answer to this question is, if you feel it throbbing, then you put your feet up. Simple as that. Get on with your lives. Go for a walk. See your friends, see your family. Go to work if you'd like. Ideally, a bit of rest is great, but if you feel it throbbing, get going. So it then gets people back to the quality of life. So we've talked about pain. We've talked about speed, or getting back to quality of life. Shoes at 2 weeks rather than 6 to 8 weeks. No plaster, which some people still have. A bandage, which I call the cuddle, because it cuddles the foot. It protects the wounds. It's not there to splint the foot. So they don't have that discomfort from that. The length of surgery. So I'm a sub half an hour per foot, which is fairly rapid. It's not done for being fast or cutting corners. It's done for expedience. So the quicker I am, the less pain there is for patients. I had a group of surgeons that came to see me from Israel, and they were watching the surgery, and they said, "Where's the blood?" I was like, "Hang on, how are you guys doing this?" And it's then the different techniques that are used to then optimize that experience. So then you think, hang on, a small cut. Okay, big cut, so you've got less risk of infection. Okay, less risk of wound sensitivity, wound breakdown. All of your risk factors are being mitigated against. When you operate on a leg, there is a risk of a clot in the leg, a DVT, or deep vein thrombosis, which can propagate up to the lungs, so pulmonary embolism. But if you're walking immediately afterwards, if you're getting on your feet and getting going, you don't need to worry so much about that. I don't need to provide them blood thinners, for example, which are quite an unpleasant experience. Patients are much more comfortable and feel the whole process is nicer. So it's really is a rapid recovery. And the massive positives that I've heard from patients are when they've had open surgery on one side, maybe years ago, maybe more recently, and they really weren't happy, and then they come across for the other foot for keyhole, and the pain differential is phenomenal. It's absolutely phenomenal. And that's why patients travel. So then it's really, why should you come to have this surgery? You know a little bit about it now, but why then come across, why take the time? But the experience is far different to the open surgery. So you can still fly internationally. I get patients who'll come into London. We scan their calves, make sure there's no sign of a clot that's brewing. They can have surgery and then a little bit of downtime before they return, and then we can do virtual follow-ups. There's the opportunity to have virtual physio. So the evolution through COVID of some of our processes to react quicker to patients, we've taken that on board, and I've certainly personally pushed this so that the experience then for patients is an overall better one. So it's definitely worth traveling to. I had a lady recently, again, stories, analogies are really good. Came across from an open surgeon, had 1 foot done, great, enjoyed it, but very, very painful process for her, and was self-employed, ran a restaurant, needed to be on her feet with her partner. So they both were very, very busy. So looked this up, and the surgeon kindly said, I'll send a letter across down to myself, and said, no problem at all, come and see me, got her across. And recently I saw her for a follow-up and said, what was the experience? What was the difference between both? Because you have to go back to work. You know, you were desperate to get back to your life, your quality. And I totally understand that as a self-employed person, there's a big, significance to this problem. She said it was just life-changing. It was a totally different experience between the two, and allowed her to do exactly what we talked about, which I think is quite nice to predict the next steps for patients. Is really quite nice. It's a tip that I picked up in Australia from a wonderful surgeon who just said, look, when you're talking to patients, it's really important that you provide that level of understanding, that they can say 2 weeks, what's going to happen, 4 weeks, 6 weeks, 3 months, what can they expect? And I think that's really nice. There are lots of gray areas where I can't say this is absolutely going to be the case, but there's a very big evolution and overlap of turning corners, showing more signs of improvement in an increment, and confidence I can provide patients, which I think makes a big difference to their overall journey.
100%. Making sure you know the expectation and then managing them is so important, isn't it? Thank you so much. When we talk about advantages and disadvantages, I was thinking, as far as I understand, there's limited visibility in keyhole surgery, or that's what a lay person thinks. How do you overcome that? And is this something people should be worried about?
Don't be worried in the right hands, basically. And the way I overcome that is I cheat. So cheating is great, okay? And this is going back to what you talked about originally about anatomy. So I love cheating with foot and ankle. It's great because I ask the patient and they use the magic fingers. They use magic. And I say, right, with one finger, point to where the problem is. And with this type of surgery we're talking about, it's very straightforward because you can see it as well. But if you know the anatomy, you can cheat. Like all good surgeons know their anatomy. So then they can cheat and get around the corner. And I use X-ray guidance. So I've got a big X-ray machine and I'm doing live surgery with X-rays, which is great. And as mentioned before, I did use virtual reality at one stage as well to then make that experience even more so. So I had a big headset on and I had a foot floating in front of me as well as the actual foot, and then images of the foot, to consume as many modalities to try and make that experience as perfect as possible. So I think with the little access, it's really important because you've got to know with those small points of contact, what is underlying those, what could potentially be damaged, how to go in. And also with images that we're using to help us do the surgery, 2-dimensional images, it's knowing the 3D anatomy of this. And so very interestingly, a lot of people may try this, and one of the failures is when you move the capital fragment or the bone that's been broken, osteotomized, but it's a 2-dimensional image, whereas it's a 3-dimensional movement. And so some companies have evolved to use jigs, so external devices, to try and guide where the next screw goes or the wires go, which is great. And I think it's great as a learning tool. But I think it's really important to be able to do both. So for example, the laparoscopic appendix. So everyone, if you have an appendix, you go in and most likely you'll have a laparoscopic procedure to have that appendix out. But at the same time, in anger, and by that I mean if there's a complication, you must be able to open the abdomen and take out the appendix at the same time. And these skills are sort of slightly lacking. So you've got to be able to do both. And I guess to close the question, with regard to the small cuts in the keyhole, trauma, so the broken bones, again, it helps me cheat. okay? Because no two bones break the same. The principles we use are the same, but then the approaches we use can be slightly different. So I think, personally speaking, and certainly when I teach surgeons, and I say, look, who's done this type of surgery? And they said, well, we haven't. I said, well, you do all of you do trauma. But the reality is they've all done minimally invasive keyhole surgery. They just don't quite know it. And it's empowering them, giving them confidence to say, actually, those principles are the same. I get what you're saying. And then paralleling those movements, because it's the ergonomic movements that I'm sure you find as well. As a dentist, your body changes into different contorted positions to get around the patient, to access the right point, and to perform whatever technique you're doing as efficiently as possible. And it's the same for orthopedics. You know, often when I'm teaching and training, you've got to bend, you've got to move, you've got to, you know, be supple, you've got to be agile, and I'm wearing a lead gown. So there's quite a lot of weight associated with it as well. Hence it keeps you quite fit. So yes, it's a great way of, you know, getting people going. But yeah, cheating with the anatomy and using trauma principles really help.
Thank you so much. Yes, it is the analogy I can think about is doing a root canal treatment on a tooth. Yes, technological advancement is great, but you'd have to know the anatomy, what is normal, what is abnormal, what variations could be there. Otherwise, the technological advancement might fail you if you don't know the basics, isn't it? That's the bottom line, I guess.
Absolutely.
Thank you so much for that. I think with the technological advancement, there is one problem. I used to be a trainer as well for dentists. I think the one problem is the basics. People sometimes feel that, you know, you don't need the basics as much as before. But without, like, for you to cheat in anatomy, you need to know anatomy well to begin with, isn't it?
Yeah, so, absolutely. It's building blocks, though, and I think, again, you're right. This is extrapolating those building blocks to everybody with everything that we do. You know, we're talking about surgery and orthopedics here, but any profession that if you know your basics, you can then move around it. And the good thing about the world is, you know, we can evolve and make things better, and we're there to push the boundaries. We're there to facilitate these movements with encouragement, you know, which I think, like I said about the NHS and other resources and groups like that, it's really important to do that. Because we can make strides and you know, positives ultimately for patients in this instance.
Thank you so much. This is a challenging question to answer, I guess. I can see from all the time now we have spent, you are quite candid when it comes to it. So do you think economics as such play a role in choosing keyhole surgery or a traditional surgery in medicine?
Yeah, it's a great, and actually it might be a bit of a myth that I could maybe dispel, actually. So health economics is crucial, and it really is health economics in the bigger picture. So now as surgeons, we're encouraged, and I take an active role in considering the augments or implants that I will use for surgery, the techniques, the style, the setup, any capital investment that needs to be made to allow that to happen. And I can reflect and contrast that with previous techniques in open surgery, and then mitigate against the maybe increased or parallel cost, but then use factors such as recovery, return to quality of life, contribution to the economy that patients will have and be able to do as well. And so there are huge points here. If I can break it down and take it back a stage, I was lucky enough to present some of my data in a minimally invasive meeting in Morocco pre-lockdown, and it was a group of, there's not many, like I said, around the world doing this type of surgery, but there were wonderful people who were kind enough to then share their experiences, both in pictorial but also numerical form, so that we could see what kind of data and outcomes that they were producing, but also the type of surgeries they were performing through this broad umbrella of keyhole minimally invasive, MIS as it's called. And I was fascinated because looking at some of the feet, I thought, wow, this looks quite swollen, quite painful, but they were insistent the outcomes were good and it was great. And then I reflected on where these surgeries were happening. And the implants being used were simple things like wires, for example, or sometimes no implants and big splints. And then if you reflect on the health economics of that country and the access they may have to implants and the things that we require or would want to do the optimal type of surgery, I don't think the access is there, you see. So there's a bigger piece here, and there's a really important understanding that we have an obligation, both as surgeons, to share best practice, to allow countries that don't have access to materials, but also now implant companies are taking on that responsibility and able to offer different deals to different hospitals and different countries, as well as training opportunities, both virtual and face-to-face, to make these kind of techniques available to all patients, which is really cool, like super cool. And it's the open-minded nature of these highly skilled, highly intelligent, people who are, I'm proud to call colleagues around the world, that allow us to do this. Actually, is really, really important. So that's going back a step. And then if you look at it in the UK, it's breaking it down often in terms of procurement processes, and that could be the procurement department, or it could be a governance process, which is through senior management, either non-clinical or clinical. There's very little to no understanding of this process, and it's a word of mouth. Oh, it must be really expensive. The reality is it's not, not only in terms of the timing for surgery or the implants, etc., but it's also the recovery periods and what can be offered to patients as a bigger picture. So you can get back to work immediately if you'd like to. A couple of weeks is ideal to rest the wounds. Whereas open surgery, you're often off for periods of weeks to months, which is fairly common. And I don't think that's doing it a disservice. I think that's an honest reflection of the recovery times required by patients. So we can all quote individual examples. I had one person that had open surgery and they got back immediately, but there'll be 99 other examples that didn't. And then it's vice versa, in my experience and in my colleagues' experiences who've gone forward. And actually, this is quite unique. I've reflected on patients, looked at my data. One of the few people on the planet to publish validated scoring systems to show outcomes from my initial cohort of patients. So it wasn't even that I was practicing and saying, oh, wow, I've got this, I've got really good now. These are the initial patients from my fellowship, off the back of my fellowship training to do this. And the outcomes are fantastic, well written up in 2019 in these long-term follow-ups in Foot and Ankle International. So, I think then it ultimately becomes a better experience and a cheaper overall experience because you're getting people back, and if you are with good conscience, whatever we do, constantly speaking to these support teams, i.e. the implant companies, how much does X and Y and Z cost? Why? And there's 5 other companies, how much do yours cost and why? And there may be a good explanation. And if actually it's just a matter of chipping away, all hospitals are now putting that responsibility onto the clinicians to say you need to be very conscious and careful about this, because the more expensive something is, the less support ultimately any system will give you from a business perspective. So it has to be worthwhile, both from the initial surgery, but also from the recovery. And I think then the final statement would go to my patients, who will then, I think, quite confidently attest to the fact that this is a better process, especially the ones who've had that open versus minimally invasive.
Yeah, I think it's database decisions is what you're saying is best for health economics, isn't it?
Absolutely. Yeah, it's important to record the data. See your patients and are you happy and are you satisfied, and lots of different ways of recording it. But I think it's important to get some sort of collection. It's very difficult with a busy practice, but as long as you can sample that, I think then you know you're doing the right thing.
Because end of the day, with loss of time or loss of working time in particular, also costs. There's a cost to it, isn't it? So you have to perhaps consider that.
And just well-being of recovery. It's a really big deal. And so, and there can be patients who it's not a race, as I say to patients, not, if they're slow to recover, then we kind of need to engage a little bit more, get them physio and get it going. And I check very carefully with x-rays, and some people, will be a bit slow to recover, in which case it's fine. It's not, as long as everything's all right in the x-rays, the foot looks great, let's get you going and just be patient, it'll happen.
Yeah, it's like a overall person rather than the ankle, isn't it? What I say to the trainees, it's not the tooth, it's a person. It's the similar thing.
Yeah, absolutely.
Thank you so much. So is there a best joint where you can have keyhole surgery on, or do you think it is generally it's good for everything? And what is the commonest condition for which you would recommend a keyhole surgery?
So I think anything that needs an operation should have as least access as possible. So let's say less invasive surgery. So we've got to minimize the soft tissue disruption. There was an old adage of big cut, big surgeon, and that's not true. It's not about us, it's about the patient ultimately and doing the right thing, which I think is crucial. And I'm sure everyone will utilize the access points that they're given to do their best for their patient. So that, isn't for debate. But I think specifically from this, and again, I look at data, there's about 25 to 30%, so nearly a third of the adult population in the UK, so you can extrapolate that number around the world, who suffer from forefoot problems, i.e. bunions. Okay, it's an inherited condition, so it's not something that you should be blamed about in terms of footwear or activities, anything like that. But it's really great through keyhole surgery, really, really nice in terms of treatment, because that is the mainstay bread and butter of the shift that's taking place from previously over 200 surgeries described, okay, to correct this problem. Now, if you can get it through small access points, and I think the hurdles of the, a wheel is a wheel. Why do I need to reinvent the wheel? That question that people asked is gone. And now surgeons are kind of like, wow, actually commercially, this is a really good thing because it kind of works in the right hands. Why can't it work in my hands? And then it's the, like when I teach, I work with different groups. And it's the understanding that actually with the right sort of techniques, with the right sort of encouragement and follow-up, the right governance structure, anyone can actually do this. It is a difficult skill set to master, but if you master the concepts of it before you even then consider putting knife to skin, then go to saw bones, which are false kind of plastic bones, versus then cadaveric studies. And then, you can do smaller versions of this type of surgery under supervision, under guidance, even as a consultant, or share that data, which should be done like this. It can be done virtually before and after with different platforms and x-rays to keep modifying and improving that process quickly. As in, you don't want to make mistakes. You want to do this as efficiently as possible. And I think within that structure, it is something that the forefoot specifically, so that the bunion is an absolute slam dunk in terms of keyhole reconstruction. It's a really positive way of approaching that part of the body.
Thank you so much for that. What skill or behavior do you think all aspiring surgeons should have, or other than surgery, what skill is best to make your team better? I think this is what we were talking about, I think, just before the show started.
Yeah, it is, isn't it? I think communication, and it's a spectrum of skills, and I think the biggest thing, which is very, very difficult, and I guess other people can comment on it, humility. It's the ability to graft and try and be humble with it, but be confident with the skill set. It's very difficult, isn't it? Anyone coming into the room as a patient, there are pros and cons to absolutely everything, and getting a message across with a degree of professionality, addressing that opinion, but then ultimately humility to take that process forwards and keep working, because without that humility, you can think you're the master of everything, and reality is there's still more to learn. There's always more to learn. In like crossing the road, there's more to learn. But anyone with kids will learn that they will teach you more than you thought you knew in the first place. So as I find on a daily basis. But I think if you can get communication with a good level of humility, the message comes across quite nicely, and then it benefits patients maximally, basically. So that's it's the hardest thing. The Rock does it really well, isn't it? The hardest working man in the room, and stay humble and keep grafting. And I think but we're lucky actually. It was. As a group of people, certainly, that hard-working ethos. It's a cultural, almost like a genetic blueprint, and it's a great thing. Whatever we do, to just keep grafting, keep working, keep driving it, keep pushing. It's really important, and trying to stay cool, which doesn't always happen in my hands. We briefly touched on this before, because I want to be as comforting on the patient journey as possible, which is really important because ultimately patients really need that reassurance. But at the same time, in the theatre environment, I'm a very different person, and I have to be there to make sure that once my patients are under that anaesthetic, everything goes smoothly as best planned. Planning is key, repetition, and making sure the teams know exactly what they're doing. There's a large volume of people on that journey with the patient, with me, and making sure that their jobs are as easy to reproduce and slick as possible. Makes that experience pretty good.
Thank you so much. It's so important to keep crafting your skill, but it's really strange when you go to these courses or CPD courses or any other, like even as a coach, it's the same people who show up all the time. And the people who we think should be showing up are not showing up. Is that something you find as well?
I do. In my training, there was a statement, there was a comment, it was more of a phrase, you're self-selected. You go on these courses and say, oh, I need to do this exam, I need to pass it, and say, you guys are all going to pass. I'm like, how can you say that? I've just walked in, and say, well, you're self-selected. And it was a great kind of line, because it means that you're putting the effort in to be there. Just by being there means that you're being diligent enough to do that. And you're right, it's not always the right person. I think, that's where the formal teaching and processes come into play, of making sure that the right feedback is given to the right trainees, and we work as a team sometimes to reflect on that. So we have different roles as trainers, as I know you know, to approach then portfolios, logbooks, and different achievements, as well as having training program directors and local educational directors, of which I've done in the past, which really helps then, because then, when I was training, I had some wonderful, really genuinely wonderful people who saw the best in me. But as I'm sure we all have, there's probably a large volume of people that probably didn't know what I could or couldn't do. And that's fine. You go with the positives, it's really important. But now I think the system means that the vast majority of people on that experience of training do know you and will have the infrastructure to support you positively and try and make you better, or encourage, like you say, the right courses and that sort of technique optimization to make the journey better.
Thank you. We are coming to almost the end, so I just wanted to ask, like, medicine is evolving every minute, like many other fields. What are the latest advancements in keyhole surgery?
Great. So yeah, I think it's the ability now to get things done a lot quicker. So it's very, very simple. So I think from my experience, it's implants are evolving to be, before they were a bit cumbersome, a bit clunky, and can be a bit disruptive. So you could have a small cut, but you can't drive a bus through it. And previously a bus would go through a big cut. And so there's an evolution of the companies to understand that these things have to be done, and to put something in. So a screw might be a small implant, but everything around it needs to be bespoke and purpose-driven to make that happen. So I think these are the hurdles that we're facing, and the challenges that are being put in front of us, and the evolutions that are taking place are the optimization of the right thing going in through the right size hole, essentially. To be very simple and blunt about it. And then off the back of that, which is again reflection on this phone call, it's the innovation of utilizing these virtual techniques and modalities and platforms to then both teach but also communicate and correspond in terms of feedback and updates from surgeons globally to say how their experiences have gone and could it be optimized. And prior to that, we'd probably send x-rays via email, etc., anonymized, of course, but even that didn't have the same feel as what we're doing, and then the next best thing is then those courses and advancements to get people in to do their face-to-face and really get that tactile feedback, which is really important.
Thank you so much. You have shared as an expert a lot of information for us. So what are the 5 must takeaways for our audience you would consider?
So I think do your due diligence is really important. So I think whatever in life, it's worth just doing a bit of reflection and seeing and get a good average of what you're going into. I think that's really, really important, because it ultimately manages your expectations. And that would be the second point, is to really think about, what it is you want out of this consultation, or, what the problem is, and are you considering surgery? Are you not? Is it, some other way of managing the issue that you're presenting with? So I think, those are the two big points. I think then after that, it's more, reflecting not just on the technique, but look up the surgeon, see what they're published, or where they work, or, see, make sure that what you want is what they can do. I think there's a lot of people out there who use the term minimally invasive loosely. Okay, most people that you could Google now and go onto a Bupa Finder or on any other list of subspecialties and say, put minimally invasive in, the vast majority of them would have it. What does that mean? Okay, so that would be my third point. It's a reflection then, and challenging. We don't challenge enough. And I'm not saying start a fight, but certainly have the conversation. Say, look, what do you mean by that? What does it entail? Why can you not do this? What does this mean? Because then I think if someone says, oh, actually I do this, and, oh, yours is too bad or too big, or that's not true. Okay, that's not true. And then if you're offered things that that don't quite match, my fifth point would be, again, I learn a lot from my patients, and it's trusting your gut. Trusting your gut with these things. We're talking about healthcare, we're talking about well-being, we're talking about, improving the quality of life that you have. And ultimately, your strap line of celebrating you, that's what we're talking about. And to celebrate yourself as much as possible, it is really important then to question, and is that positive? Is that exactly what I wanted? That's really important, because it's empowerment, isn't it? I think it's really important.
Thank you so much. I think doing the right research, clarifying questions, and then always knowing you have a choice to make, isn't it? So thank you so much. Yeah, you do.
Yeah, because we're not, there are some very clever, very skilled surgeons and doctors, clinicians and teams out there who look after some horrible life-threatening conditions, and, incredibly intelligent and selfless people. What we're talking about today is these aren't life-threatening conditions. These are improving quality of life, taking away pain, and that is a big deal for a lot of people. But to put it into context, so you have time to think. You must always take your opportunity of time to think. I think it's really important.
Thank you so much. We have learned so much. I have definitely learned a lot about ankle surgery, keyhole surgery, which I didn't know much about at all. So Thank you so much for enlightening us with all the knowledge and wisdom you have. What has been your experience on the talk show?
It's been brilliant. No, thank you. So first of all, it was wonderful to be reached out to, and wonderful to connect. I always like to know that there's different groups of people, also communities, be it through sport or work or here socially, to improve the experience of life for others. I think the key word here is positivity. It's wonderful, and it emanates from you and your team. I'm very grateful to your patients. Specifically around me, because I know that I'm a nightmare to get hold of, and are constantly doing something or another. So I am really humbled by being asked, and then for your patience through this whole process. And please keep doing what you're doing. There are more people that I know will benefit from knowing that you do this, and bringing groups of people together, communities together around the world, which is sensational. Really is. I can't believe this is an easy thing to do, and now to reach those 90 milestones of episodes, it's huge. It's absolutely huge. So I think you guys should be really proud of what you're doing put together. It's incredibly professional, and I got to say it was very easy for me, very slick. Actually, but yeah, I'm sorry it was quite late with coming back with stuff.
Thank you so much. Proof is in the pudding, and then you came and you made us, want to bring you back on the show. So
wonderful, delighted.
Thank you so much. It was a delight to have you. Thank you. Now, following tradition, I'm going to announce the speaker for the next week. That is the episode 98. We will be talking about resiliency, a story of resiliency, prisoner to professional, with Roy Ratnawale. He has recently written a book about to be published, which is called Prisoner Number 1056. Roy Ratnavale is an Executive Vice President of CI Financial and the Head of Distribution at the CI Global Asset Management, largest independent asset manager firm in Canada. He currently leads CI's national distribution team that oversees CI's retail business assets over 170 billion. He is a board of director of the Investment Fund Institute of Canada and the Aristotle Foundation for Pupils Policy. Roy is also the recipient of Report on Business Canada's 50 Best Executives 2020 award. He summited Mount Kilimanjaro in 2019 to raise awareness about mental health. But the bigger story is the world's largest publisher, Penguin Random House, publishing his extraordinary survival story from a teenage prisoner in Sri Lanka to a successful professional in Canada. Cannot wait to have him on the show. And like as many of you know, resiliency is something I totally believe in, and I cannot wait to have him on the show. Now over to Dr. Kanta Niranjan to give the vote of thanks.
On behalf of Meet Menaca Group, I really like to thank Mr. Kumar Kunasingam, and outstanding, excellent orthopedic surgeon who studied under the prestigious Professor Harold Ellis. I don't think any medical students would have escaped not studying surgery of his book, including me. And this you are really, and so if you have studied anatomy, they say you have studied more than half of the medicine. And we are very, very privileged to have you today, and your talk explaining, giving good examples, and sharing the knowledge. And it has been a very good eye-opening for most of us. I'm sure people who watch the YouTube video later will learn a lot as well. Really, thank you very much for taking your time for be with us today afternoon. I'm sure a lot of people have a lot of questions, so I will leave with that. I will not ask any questions as Meena has suggested. I'll send a question to Meena later. Thank you very much, Mr. Kunasingam. Thank you very much.
Thank you. That's really kind. Thank you for your kind words. I appreciate that. Thank you. It's an absolute pleasure.
And thank you so much, Dr. Kanta Niranjan. From myself and the team, a huge thank you, Mr. Kunasingam, for coming on the show and sharing your wisdom. And I know it's sun is shining outside in the UK. It's a big deal for you, and for you to spare the time and come on the show and share the wisdom as well. Huge thank you for people who are on the show. And many of you, I know, week after week, almost from the beginning, you have been supporting us. So huge thank you for all of you. People who are listening to us on the Facebook, again, thank you so much for supporting us week after week and putting the questions, suggesting topics. Without you, we wouldn't be almost reaching the 100 shows. So huge thank you for all of you. Now, it is almost time for us to wrap up for the day. Till we see you next week, same place, same time, to talk about resiliency with Roy Ratnavale. Stay safe, be happy, and keep smiling.